Welcome to the Mayo Clinic Cardiovascular Masterclass.
These are my disclosures, not relevant to what I'm going to talk about. So I'm going to start out with HFrEF, which we used to call systolic heart failure with reduced ejection fraction. And it says pathophys and diagnosis, but I'm really going to focus on pathophysiology here, a little bit more about diagnosis later, and it's usually quite straightforward. So in HFrEF, this is sort of how it works. There's some insult to LV function, and it could be something really obvious and clinically overt, like an MI or myocarditis, or something very indolent and slowly progressive, like a sarcomeric gene mutation. But this leads to a reduction in cardiac output and blood pressure, which is sensed by the body, and it leads to some adaptations. There is neurohormonal activation, sympathetic nervous system, renin-angiotensin-aldosterone. This then leads to two things. So at the cardiac level, there is increases in heart rate and contractility from beta adrenergic stimulation. There is vasoconstriction to maintain blood pressure, and then at the kidney level, there is an increase in sodium and water retention to increase preload to maintain cardiac output by the Frank-Starling principle. And these things are then all designed to preserve cardiac output and maintain blood pressures in a range that we need to stay alive. So this system is very good if you're exsanguinating and you've been bit by a tiger. So it's been adapted for or selected for millions of years. But chronic activation of these pathways is very bad and really begets progression of heart failure with reduced EF. So the important concept here, and this will come into the treatment section later, is that the body's adaptation, or really maladaptation, to the insult becomes more important than the insult itself. And that's basically how we treat it in a nutshell. Now, I'm going to transport us all back in time to medical school to understand qualitatively what happens in heart failure. So excitation, contraction, coupling. So this is a cardiac myocyte in cartoon, and when the cell depolarizes, a little bit of calcium comes in through the L-type calcium channel. This then binds to the ryanodine receptor on the sarcoplasmic reticulum, which is where most of the calcium is stored, inside the cardiac myocyte. This then triggers the release of a large amount of calcium into the cytosol, which then can go bind to troponin and activate the thick-thin filament interaction, which causes contraction. So it's all about calcium. More calcium, enhanced contractility, less calcium, vice versa. Calcium then is taken back up into the sarcoplasmic reticulum by this protein called SERCA, the sarcoplasmic reticulum calcium ATPase. About 25% of it is extruded from the cell via a channel called the NCX, the sodium calcium exchange channel. So this is what happens every heartbeat and what happens in heart failure. You don't need to know specific mutations for this, but it's important to understand qualitatively that you have abnormalities in calcium handling. There is leakage of calcium from the ryanodine receptor. There is less SERCA activity, so you have less calcium in the sarcoplasmic reticulum. And a lot of novel therapies, the state-of-the-art lecture, so state-of-the-art sort of therapies are targeting this. So, for example, gene therapy has been, trials have been designed to enhance SERCA activity, to increase the amount of calcium in the sarcoplasmic reticulum, to use this as a way to enhance contractility. So calcium handling becomes very abnormal in patients with HFrEF, especially when heart rate increases. So they have an abnormal force-frequency relationship. This is another important signal transduction pathway, again, back to medical school to remember, to keep in mind. This is the beta adrenergic pathway in the heart. So norepi, or epinephrine, stimulates the beta receptor. That activates GS, which causes conversion of ATP to cyclic AMP, which then activates protein kinase A, which phosphorylates a number of different proteins in the cell that enhance calcium handling. So it phosphorylates a protein called phospholamban, which decreases its inhibition of SERCA, so SERCA works better. It phosphorylates troponin so that calcium is taken away faster and the avidity for calcium is decreased. It affects the metabolism in the cell. It increases the rate of contraction, the force of contraction, and the rate of relaxation. So these are all good things. What happens in heart failure, in chronic heart failure, is that you get desensitization of the beta receptor. So the beta receptor, you have fewer of them that work properly. They become uncoupled from this stimulatory pathway. So for any amount of epinephrine or norepinephrine signaling, you get less beta-mediated effects. And this is why beta blockers work so well, because they restore this beta adrenergic sensitivity in chronic heart failure. And this is just a table to review what happens with alpha stimulation and beta stimulation in the heart and elsewhere, and I'm not going to go through with that. Another important pathway to remember, a good pathway. So these are good acutely, but bad chronically. This is a counter-regulatory pathway. This is the nitric oxide natriuretic peptide cyclic G pathway. So NO, we know, nitric oxide is a gas which diffuses into the cytosol and stimulates soluble guanylate cyclase to increase cyclic GMP levels. So similar to pKa, which is activated by cyclic AMP, cyclic G activates a protein called protein kinase G. This antagonizes much of those effects. So you see a decrease in growth and hypertrophy. You see a decrease in myocyte stiffness. You see a decrease in calcium avidity. So you see enhanced diastolic function, and in some studies, a break on the contractile function. So this is a good thing. Another way to increase cyclic GMP levels in the cell is by enhancing the natriuretic peptide pathway. So BNP and ANP bind here. They work through a different guanylate cyclase that's near the membrane, but they lead to the same thing, an increase in cyclic GMP and all these positive effects. In addition to increasing cyclic G through nitric oxide and natriuretic peptides, you can enhance it by decreasing its breakdown with phosphodiesterase 5 inhibitors, like sildenafil. These have been tested in HFrEF and did not work. This is an important target in patients with pulmonary arterial hypertension, and there's still hope this pathway might be effective in patients with heart failure and reduced EF. Now, this is an electron micrograph of the cell, and you can see myosin, thick filaments, thin filaments. The thick filaments, myosin, are connected to this Z band by a protein called titin, which is emerging as a very important player inside the cardiac muscle cells. Titin is the largest protein in humans. It acts like a bidirectional spring so that when you stretch it further, it wants to oppose that stretching and leads to a greater increase in pressure. And then like another spring, if you compress it down too far, it's going to want to recoil back, so it can have this restoring force. Now, titin, interestingly, has different isoforms, has stiffer and less stiff isoforms, and those might be important in heart failure. But you can also phosphorylate titin and affect its stiffness. And a nice study from Maggie and others have also shown that if you increase the phosphorylation of titin with things like sildenafil, which increases cyclic G, or BNP, you can actually decrease the stiffness dynamically of heart muscle cells. So this is another reason why the NO, natriuretic peptide pathway, may be effective. We've tested natriuretic peptides in clinical trials. They didn't work, but we have a new compound that we'll hear some more about, the neprilysin inhibitor, that works via this pathway. And this is the mechanism at a cellular level by which this occurs. Now, chronic neurohormonal activation causes this. So you've got this normal small heart, and it gets really big. And I put this up here because this is the law of Laplace. This is wall stress. It's equal to the product of chamber pressure, so LVEDP, times chamber dimension or radius divided by wall thickness. This gets very high in chronic heart failure, and as the ventricle dilates and becomes more spherical, in addition to that increase in wall stress, you have many other bad things happening. Increase in oxygen demand, decrease in pump efficiency. The mitral apparatus and the tricuspid apparatus get distended, and you get functional mitral and tricuspid regurgitation, and then you get desynchrony. So all of these bad things are important targets. And most therapies that work in HFrEF, really all therapies that work, cause reverse remodeling, cause this ventricle to get back towards this. That's really the target that we look for structurally. There's a number of pro-remodeling hormones. I think everybody's pretty aware of this. There are these anti-remodeling that we talked about. We know that therapies targeting or antagonizing these pathways are very efficacious, and we'll hear more about that in the subsequent lectures. We've tested therapies that either antagonize these pathways, endothelin and vasopressin, or that activate these pathways, and they largely haven't worked. We still don't know about nitric oxide. Again, if you talk about the natriuretic peptides via neprilysin, that does look like that works, but these tend to antagonize each other. These are doing good things, anti-proliferative, anti-hypertrophy, and these are doing the bad things. I think it's worthwhile really focusing. I know you've talked about mechanics and ventricular arterial interaction before, so I'm going to go over it one more time. This is a PV loop. So pressure on the Y, volume on the X. Normal ventricle fills with blood during diastole here, up to the end diastolic pressure. And then the mitral valve closes, onset of isovolumic contraction. So pressure is going up, volume is staying the same. Aortic valve opens here, volume is decreasing as the ventricle ejects blood. Here, the aortic valve closes, ejection has been completed. Volume stays the same, but pressure goes down. This is isovolumic relaxation. So this is a single heartbeat over and over and over. And this is the end diastolic volume, which we define as the preload to the ventricle. This is the end systolic volume. Obviously, the difference between the two is the stroke volume, blood pressure, end diastolic pressure, and then the area shaded here is the stroke work, the hydraulic work performed by the ventricle. So as if this isn't enough, if you really want to understand ventricular arterial mechanics, you need to measure a PV loop not just at steady state, but with changes in preload. So for research purposes, what we do here is we inflate a balloon in the IVC. So venous return coming to the heart goes down, and you can see that the EDV is going down. The end diastolic volume is decreasing, decreasing, decreasing. Therefore, the stroke volume is getting smaller, and the systolic blood pressure is going down. If you then connect those end systolic pressure volume points, you get what's more or less a straight line called the end systolic pressure volume relationship, or the ESPVR. That is a measure of contractility. The slope of that line is contractility. So as that slope goes up, enhanced, and then in HFrEF, it would be blunted and it would go down. This line is the diastolic pressure-volume relationship, or passive stiffness. It's not a straight line, it's curvilinear. So as you try to stretch these tissues, they have a nonlinear stress-strain relationship, and the pressure goes up. There is also going to be a negative slope going through these lines called arterial elastance. That's how we express afterload, EA. It is the ratio of end systolic pressure to stroke volume. So as you can imagine, as blood pressure gets higher, stroke volume gets smaller, that's afterload going up, so EA. So if this slope is steeper, that's an increase in afterload. As this slope goes down, that's a decrease. So if you understand these principles, you can understand how different hearts respond to changes in load. So on the left is a normal heart, and you give a vasoconstrictor like phenylephrine, and you can see an increase in blood pressure, a decrease in stroke volume, the loop is getting narrower. If you do the same thing to somebody with HFrEF or systolic heart failure, you see the same things. The blood pressure is going up, the stroke volume is going down. But because of that very shallow ESPVR, you're getting a much more dramatic effect on volume and less on pressure. You're seeing a greater reduction in forward stroke volume. If you give a vasodilator, so you're reducing that arterial elastance, you're also, again, you're seeing a drop in blood pressure, and then the PV loop is getting wider, stroke volume is going up. You give a vasodilator to a patient with HFrEF, you see the same thing occurring, but again, the increase in stroke volume is much greater, and the drop in blood pressure is less. This is the hemodynamic reason why we aggressively push vasodilators in people with HFrEF, and you can really push hard on those therapies, often without seeing much blood pressure reduction. So push hard. So this is what we see. I'm going to go through here quickly to try to catch up. We have different stages in HFrEF. There's stage B. Those are people that have some sort of structural disease but no symptoms. They have a low EF, but they have a low EF because their EDV, the denominator of the EF equation, is big. Their stroke volume is actually normal, and their blood pressure is normal. So this is the earliest stages of HFrEF. People with stage C disease, their ventricles are more dilated, but usually their stroke volume is normal, so the width of the loop is the same and their blood pressure is still the same. But they're symptomatic now, so now you're starting to see an increase in the end diastolic pressure. It's not until the end stages, the patients where we're thinking about VAD and transplant and putting in ECMO and doing crazy stuff like that, where they start to look like this, where they start to see an actual drop in blood pressure and a reduction in stroke volume. So this is really the progression of the disease. We want to move these people back into this category, and this explains this in the pressure volume plane. An important principle to remember pathophysiologically in HFrEF for treatment is this concept of decreased preload sensitivity. So there's enhanced afterload sensitivity. I told you as you bring the afterload down, you get more forward perfusion, but there's decreased preload sensitivity. I'm going to show you that here. These are Starling relationships. So these relate filling pressure, wedge pressure, or LV-EDP to stroke work. Or you could plant stroke volume over here. You'd see the same thing. If you take a normal patient and you give them a diuretic and you see this reduction in filling pressure, you're going to see a drop in stroke volume and stroke work. If you do this to a patient with HFrEF who's way out here on the asymptote of this flat portion of their blunted Starling relationship, you're just going to move from here to here. You're going to reduce filling pressure, and that's going to be good for the lungs, but you're really not going to see a reduction in stroke volume or stroke work. So this is why we can really push the diuretics hard when these patients come into the hospital. Now, some people with really advanced HFrEF look more like this. They have this apparent descending limb of their Starling relationship, and when you give them a diuretic, they actually see an improvement in stroke volume. So how can this work? Well, it's not because there is a true descending limb at the level of the cardiac myocyte. It's due to a phenomenon that we call diastolic ventricular interaction. I'm going to explain that to you here. So here's a cartoon, a parasternal short axis view of a normal heart, RV, LV. If I do something like apply lower body suction to decrease venous return to the heart, the RV gets smaller because less blood's coming out back to it, and then the RV pumps less blood to the LV, so the LV gets smaller. If we do this same experiment to somebody with really advanced HFrEF, who might look like this on their echo, big distended RV, we decrease filling to the RV. The LV then takes advantage of that, and all that extra blood that's dammed up in the lungs can then go into the left atrium and left ventricle and enhance LV filling, and the septum bows back over. So even if filling pressure goes down in this circumstance, filling volume, which is the real preload to the ventricle, goes up. We can estimate this by looking at what's called the transmural pressure. Transmural pressure tells us the forces that are favoring filling of the ventricle. And it's defined by the pressure that you measure with your catheter minus the external pressure applied to the ventricle. And that's the force that's really enhancing filling of the chamber. So how do you measure that external pressure? That's the pericardial pressure, and it turns out you can estimate that pretty effectively using the right atrial pressure. So you could look at somebody with a wedge pressure of 32 and say, wow, their preload is super high. But not necessarily, because in this patient, the right atrial pressure is also very high. So the difference between the two, the transmural pressure, is quite low. This LV is actually underfilled. And if you did an echo, you might see something like this. Huge RV, septum is bowing over, LV is small and underfilled. If you take this patient and you diurese them, or you give them a nitrate or a lower body suction or do something to decrease venous return to the right heart, you can see wedge goes down, but preload actually goes up because the LV has gotten bigger, and that's because this transmural pressure has increased. The RA, the pericardial pressure, has gone down more than the wedge pressure and the LV-EDP, and you see better filling now. And this comes up all the time on the management of inpatients with HFrEF. This is why when the BUN is 90 and the creatinine is 3, we still push the diuretics, because the LV is actually underfilled and we need to decrease that ventricular interaction, and they do better, and the renal function gets better. Other common hemodynamic findings that we look for in HFrEF, pulmonary hypertension is very common in these people, shown here. We often see functional mitral regurgitation. You can see these big V waves here. So when you see a big V wave, you always think that. Or if it's a post-MI patient, you think of a ventricular septal defect. I would mention that giant V waves are neither sensitive nor specific for mitral regurgitation. It's important to remember, but when you see it, you certainly think about it. We often see people with severe tricuspid regurgitation in heart failure as well. What happens with pulmonary hypertension, very, very common, present, especially when you get into stage C and D heart failure, almost everybody has some element of pulmonary hypertension. In the early stages of the game, it's just due to left atrial hypertension. So remember, mean PA pressure is equal to the product of cardiac output times PVR plus the downstream left atrial pressure. When that left atrial pressure goes up, even if everything is normal in here, it has to drive the PA pressure up. We call this passive pH. As this goes on for a long period of time, whether it's due to heart failure or mitral stenosis or anything, you start to get pulmonary vascular remodeling, the transpulmonary gradient, which is the difference between mean PA pressure and LA pressure or wedge pressure, goes up, and the PVR goes up. And then you start to see an even greater increase in PA pressure. This is called reactive. It's also called combined pre- and post-capillary hypertension. This has the worst outcomes in HFrEF. This is worse than patients without pulmonary hypertension. You're best off if you don't have PH. And recent studies have shown you if you titrate therapies in HFrEF or HFpEF to reduce PA pressure, you can actually reduce heart failure hospitalizations. Why is pH bad? Well, the RV is not well suited to pump against high pressure load. It's much thinner, doesn't have the appropriate geometry. The LV laughs at a 10 millimeter increase in pressure, no problem. It can easily maintain its stroke volume even as afterload goes up. But a 10 or 20 millimeter increase in PA pressure causes a dramatic decrease in RV stroke volume. This is why PE, pulmonary embolism, can be so catastrophic. It's acute afterload mismatch. But the same principle applies in patients with heart failure and pulmonary hypertension. Number of different extracardiac sequelae. So I've focused really on the heart from the cell level to the organ level, but it's really the whole body that gets affected in heart failure. And that's why a lot of us are really interested in heart failure, because it becomes this systemic disease. With passive congestion of the liver chronically, you start to get hepatic dysfunction, you get ascites, you get problems in the bone marrow, anemia. Endothelial dysfunction is very common. It's very important in HFpEF, we think, as well, and Maggie will talk about that in just a second. Sleep disordered breathing is very common, and oxidative stress increases as well. A couple words about cardiorenal syndrome. Renal dysfunction, very, very common, big problem in heart failure. You can see that most patients with chronic HFrEF have at least stage 3, if not worse, kidney dysfunction. The pathophysiology is complex. We used to think it was just due to poor perfusion from inadequate cardiac output, but it turns out it's more related to central venous hypertension. So as your RA pressure gets high with RV failure and pulmonary hypertension, the IVC pressure and the renal vein pressure gets real high, and that's probably a more important player. And that's another reason why aggressively pushing the diuretics can actually enhance renal function in these patients. Patients with more severe renal dysfunction clearly do worse, and it's a very strong indicator of adverse outcome in patients with advanced HFrEF. It goes beyond that as well as heart failure, again, becomes really severe. Again, that's stage D, the most advanced stages, the people that are in and out of the hospital all the time. They start to get problems in their skeletal muscle. So chronic LV dysfunction, decreased perfusion, decreased activity. They start to get muscle wasting, which causes fatigue and breathlessness and causes more sympathetic activation. And they start to break down muscle, and they see qualitative and quantitative changes in their muscle. You don't need to know the exact change in the fiber type, but understand that there are important changes in metabolism and muscle function that importantly contribute to symptoms. And when these people, you start to see this temporal wasting or the thenar eminence is starting to get small, that's really an indicator of advanced HFrEF. Part of what also happens here, for unclear reasons, with this chronic venous congestion and right heart failure is they start to get inflammation. And studies dating all the way back to the 90s have shown increases in TNF levels. You can actually measure endotoxin levels. They're higher when you're congested. When you decongest patients, the endotoxin levels go down. This is believed to contribute to this. It's not clear. But this pro-inflammatory pathway leads to and worsens LV dysfunction. It's also believed, as Maggie will talk about a little bit, to contribute to the syndrome of HFpEF. In HFrEF, it's thought that the inflammation is secondary to the chronic heart failure and the passive congestion. The current thinking is that in HFpEF, it precedes it, and things like obesity and diabetes cause a little bit of low-grade inflammation, which causes it. And again, we'll hear some more about that, I think.
We hope you enjoyed this presentation.